Good afternoon. My name is Roger Citron. I'm the director of the Drug Use Research and Management Program, and we welcome you to the April edition of the Oregon Fee-for-Service P&T Committee. This meeting is being recorded, just to let you know, and a copy of this recording will be posted to the with a link to the OHA's website. Um, there's some general announcements and guidelines that are on the screen. Again, we ask for those that are in attendance to try to rename yourself and your phone number to your name and your affiliation so we can accurately capture that for our meeting minutes. And we have two more staff joining, so pause with me. It's hard for me to walk and chew gum, so I need to click a couple buttons and all right, I think we're up to speed. So for those in attendance, we will be posting the materials on the screen as we go through the meeting, but we've also have a full copy of the meeting packet posted to our website. You can follow along. I'll call out the pages as we move through the agenda. At the top of the order here, we're going to do roll call and introductions. So we'll start off with the committee members. I didn't see, there's Karen. Give me 1 second to make you a co-host. Tim is unfortunately unable to join us today. Karen, are you able to unmute yourself?
Hello, can you hear me okay?
Hear you loud and clear. Thank you.
Excellent. Hi, this is Karen Michelson. I'm the pharmacy director for the Coquille Indian Tribe in Coos Bay, Oregon.
Welcome. Robin,
I'm
are you
Robin
able to unmute?
Moody. Yeah, hello, Robin Moody, Executive Director of Dental 3 and P&T member.
Welcome.
Bill Origer. I've had a bit of a job change since the last meeting. As I inch towards retirement, I've retired from the residency faculty, but I'm currently physician advisor to hospital utilization review for Samaritan Corvallis. I'm a family physician.
Thanks for being here, Bill. Sorry we're not in person to see your newest photographs.
I'm Doug Carr, internist, medical director at Umpqua Health Alliance in Roseburg.
Welcome. Russ is unable to join us. Dr. Nishi, appreciate the email. Are you able to unmute? I saw Dr. Anishi join. I made her co-host, but she may have had to drop off for a moment. So Eddie, let's move to you.
Sure. Hi, everyone. Eddie Saito, clinical pharmacist with Virginia Garcia Memorial Health Center and associate professor with School of Pharmacy at Pacific University.
Welcome. Pat?
Hi, everybody. I'm Pat DiMartino. I'm a pediatrician and hemonc doc at OHSU, where I'm also faculty.
Welcome. Kat.
Hi. Yeah. Hi, this is Kat Livingston. I'm the medical director of HealthShare and a practicing family physician at OHSU.
Welcome. Stacy?
Hi, everybody. I'm Stacy Ramirez. I am faculty at OSU College of Pharmacy and a clinical pharmacist and director of pharmacy for the community health centers of Benton and Lynn counties.
Welcome. And Dr. Anishi, are you able to unmute now?
Yes, I can. Hello, I'm Erica from Family Medicine, OHSU.
Welcome. Stacy is our chair. She'll be running most of the meeting, but does have some responsibilities to drop off and take care of one of her classes that she has to cover. And so at that time, during the break, we're going to do a handoff and have our vice chair, Dr. DiMartino, take over as chair for the remainder of the meeting. At the same time, Robin has to drop off at the same time, about 3:30. I just wanted to find out from the rest of the committee to ensure that you all were going to be able to attend throughout the meeting until 5 o'clock or so. Hopefully we'll get done a little bit sooner, but we want to maintain that we have a quorum. If not, we need to shuffle and take care of business before we lose those two members. Great. It looks like we should have a quorum even with their departure. So we'll go forward with the agenda as posted to our website, and we'll now do staff introductions. Jennifer, are you able to unmute? I saw you join.
Yeah, Jennifer Bowen, Oregon Health Authority Executive Assistant.
All right. Roger Citron, Director of the Drug Use Research and Management Program.
Trevor Douglas, Pharmacy and Purchasing Director for OHA.
Hi, Dave Ingen, a clinical pharmacist with the OSU Derm team.
Sounding good, Dave.
Sarah Fletcher, I'm one of the clinical co-coordinators for the Derm team.
Andrew Gibler, Clinical Pharmacy Manager with OHA and also a small faculty appointment with the College of Pharmacy.
I'm Kyle Hamilton. I'm the Pharmacy Drug Coordinator with the Oregon Health Authority.
Hello, I'm Megan Herrick. I'm a clinical pharmacist and faculty with the College of Pharmacy.
Hi, I'm Deanna Moretz, clinical pharmacist with the Durham and OSU College of Pharmacy.
And I don't think Amanda was able to join today. Kathy?
Sure, I'm Kathy Centena, and I'm a clinical pharmacist as well with the OSU Derm team.
Hi, my name is Sarah Servid, and I am the P&T Clinical Co-Coordinator with the Durham Group.
Lance Starkweather, Pharmacy Manager for Gainwell Technologies.
Hi, Dee Weston, Pharmacy Program Policy Advisor with OHA.
Hello, my name is Brandon Wells. I'm the Pharmacy Program Analyst in the Fee-for-Service Program for OHA.
Ted wasn't able to join us, but we do have a resident that'll be presenting one of our topics today. So Melissa, are you able to unmute?
Can you hear me okay?
You bet.
Yeah. Hi, I'm Melissa. I'm the PGY2 resident at OHSU Richmond Clinic, and I was working with the Durham team on a drug use evaluation.
Appreciate it. Thank you for joining. Conflict of interest declaration is next. All the staff and the committee members have filled out a conflict of interest declaration with the OHA. In addition, anybody wishing to provide public comment, we do have one person today, fills out a short conflict of interest declaration. It's vitally important that the OHA is aware of that, and committee members bring any conflicts to the attention of the OHA. With that, we will see if anybody has any conflicts, new conflicts that they need to announce, or any topics for which they need to recuse themselves today. As expected, I didn't hear any. Next, we'll move on to the approval of the agenda and the minutes. The only change to the agenda was, as I mentioned, we'll have a switch in chair towards the latter part of the meeting. As far as the minutes, I sent those out to the committee in advance for your review. If you're following along on the packet on the website, those can be found on pages 5 through 9. Are there any edits or updates that need to be reflected in the minutes? And if not, we would entertain a motion to approve.
So moved.
In second.
All those in favor?
Aye.
Aye.
Hi.
Aye.
Anyone opposed? And abstain?
I'll abstain since I was absent.
Oh, perfect. Thanks, Eddie.
Thanks, Eddie. Great. Next, we'll do the department updates. So we'll turn it over to Andrew Gibler.
Yeah, I know a few of the committee members need to leave early, so I'm just gonna, we've been so knee deep in different projects that I'm not sure what's been happening with the departments, but I think if I'll yield back my time, and if anyone has any specific questions about anything regarding events at OHA, please feel free to ask now, and a few of us are on here, so we could probably answer.
Any direct questions for the OHA? And you can always email me and we can find answers for you later, but if you have one now, by all means. All right, hearing none, we'll do the legislative update and turn it over to Dee.
Apologies. I was briefly distracted there. So yes, there are a lot of bills, and also in the interest of time, I don't know that it's worthwhile to go through many of them. One bill that would have had pretty significant impacts to P&T operations, that was House Bill 2499, is no longer active, so we don't expect that to be taken back up. There are a lot of other bills, but I don't think any of them will have significant impacts. So in the interest of time, like I said, I'll just yield my time as well, unless somebody has a question.
Thank you, Dee. Any questions for Dee or anything about legislation that you're following? Okay.
All right.
With
thank
that,
you.
the next part of the agenda, I'm sorry.
Thanking you. That was it.
Oh, sorry, I spoke over the top. Starting on page 10 in the packet, we have our oncology PA updates. They're usually standing consent agenda topic as we add new agents that will be subject to NCCN guidelines. We also have a glaucoma drug class update in NDE. Generally, any topic that we put with this kind of information in the consent has no clinical information, so we're just going to be reviewing an executive session. No one has signed up for public comment that we're aware of. Does the committee wish to take any of these off to review? And if not, we would entertain a motion to approve the consent agenda.
Roger, I
Yeah,
have
Dr.
I don't have any desire to take it to take off the consent agenda. I just had I was going through the rationale or the step criteria for use. You know, we utilize FDA and then NCCN guidelines. When the diagnosis is consistent with an NCCN protocol, and there's more than one protocol option, is there further evaluation about the options in terms of lower cost? Is that ever brought into the picture?
No, as long as it's meeting, this particular agent is meeting the NCCN guidelines and it's the appropriate place in therapy, we are not doing a further stratification to require one over another at this point. Lan, you can correct me if I'm wrong.
No, that is correct.
And this is, just to add to this, the oncology PA we have had in place for a couple years now. And so one thing we could take back is maybe do a policy evaluation of this criteria and see where our utilization is and what it looks like.
Yeah, just some observations from our own, evaluation at a CCO. The newest is the most expensive. It's also the most attractive sometimes because they're earlier, it's not as well established what the pitfalls are and the benefits, the purported benefits are much greater. And then over time you find that they're less beneficial. But there's also a clear incentive for an oncologist to use the most expensive drug because reimbursement is based on the expense of the drug as a percentage. So what we've found is that many times that there's really no rationale for not using a standard therapy with the, when there's a gee whiz alongside it.
Appreciate the feedback and the question. Sarah, go ahead.
I guess I'll second the notion that Sarah raised that maybe a policy eval and seeing what our utilization has been would be interesting. Because I think when we made that sort of big lump oncology PA approach, it was under the assumption that there's very, very little utilization.
Okay, appreciated. So I would move for approval of consent agenda.
Thanks for the motion. Second.
Second.
All those in favor?
Aye.
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 Anyone abstain? All right, thank you. And I realize I forgot to ask, is there any no's? All right, thank you, everybody.
Yeah, great recommendation and timely. Next, we're going to move on to our DUR news business, starting on page 38 in the packet. We're going to start off with Andrew Gibler.
Okay, thank you. This is a brief presentation on what the Mental Health Clinical Advisory Group approved recently for generalized anxiety disorder. And we wanted you to take a look at this before you consider any policy decisions. So let's see. Okay, thank you. The first line of treatment is for generalized anxiety disorder. Are the SSRIs, escitalopram or sertraline, or the SNRIs, duloxetine or extended release venlafaxine. There are other options that the committee recommended. One being the tricyclic antidepressant imipramine, and the other being bupropion ER. And the imipramine has moderate quality of evidence for effectiveness, but of course it's not tolerated as well, and so that is more of an alternative agent, but still considered first line, perhaps in some people that the provider may feel could benefit. Bupropion ER just hasn't been studied as much, but in the few studies that it has been, has shown that it's relatively very effective for generalized anxiety disorder as well. The next slide shows adjunctive treatment, and the Mental Health Clinical Advisory Group recommends 3 trials of a first-line treatment if possible. Trial could be stopped either because it's not tolerated or because it's not effective in the first several weeks. However, after a number of weeks, if there's some improvement that they, but we're not close to remission or anything that's clinically significant, then they recommend adding an adjunctive treatment with pregabalin. And pregabalin is shown to be very effective as an adjunctive treatment to an SSRI or SNRI in generalized anxiety disorder. Buspirone is second-line adjunctive treatment if pregabalin is not an option. Unfortunately, because of the half-life of it, it just has to be dosed so frequently, and so it's not well used, not commonly used in clinical practice. So many providers are just not as familiar with the dosing and titration of that. And then lastly, other adjunctive treatments include quetiapine extended release, which has shown great efficacy, but is very limited by side effects. And but it has been shown to be very, very effective. Hydroxyzine is not used. Antihistamine has got a lot of sedating effects, but it too has been studied and has shown lower quality evidence of improved efficacy for GAD. And then diazepam or lorazepam have been studied in generalized anxiety disorder as well, but are very limited by all the factors that we've talked about before regarding benzodiazepines. And so this would be a last resort. And I'll show you where the algorithm on the next slide will just kind of show you a brief overview of what the committee had discussed. And I won't go into detail, but you have these trials of first-line therapy in the middle, and you initiate it, and after 4 weeks, you're looking for clinically meaningful improvement, and that's kind of discussed in the guideline text a little bit that they wrote up, and you move on from there, starting a new trial or moving on to adjunctive treatment and reevaluating if it is very effective against the treatment is effective against for the patient, then continuing for at least 6 to 12 months and making sure those symptoms are gone or mostly gone because of there's concern with withdrawals of GAD if you're taking off these medicines too soon. And then the next slide talks about the algorithm for the adjunctive treatments, and so it starts out with pregabalin on the upper right, and from there you target to a dose of 150 to 600 milligrams a day, no more than that, before moving on to two other options if that's not effective, including which would include buspirone, and then if buspirone isn't effective and pregabalin isn't effective, then referring to a mental health specialist before going any further and starting an antipsychotic like quetiapine or benzodiazepine. Benzodiazepines are recommended initially in the first week or two if it helps the patient get over that initial couple weeks of treatment, but no more than that. And so I think that's the last slide, but that is, if you have any questions, please feel free to ask. These are posted on the Mental Clinical Advisory webpage, I believe now. So you can access that as a resource anytime, and they're designed for busy primary care providers. So they're hopefully short and sweet and usable. And with that, I'll ask Bill, do you have a question or comment?
Looks like you're still on mute, Bill.
Click the wrong
There you
thing.
go.
Sorry, normally when we make a recommendation, we review the evidence, and there isn't any evidence presented on this. So tell me about it. Yeah.
So we, if you go to the document, you will, on the MCAG website, this is just a presentation I put together. It's not, doesn't list all the references. I think there are about 18 references utilized. We utilize the same methods that the Durham group uses for PNT. So high quality systematic reviews and high quality clinical practice guidelines before, and I do the background research and present that evidence to the MCAG. And they take that and then, as I like to call it, add their specialty and experience, kind of add to that a little bit. And for the most part, it stays the same. It's very evidence-based, but they may have different thoughts and nuances that we deal with that's a systematic review, for example, can address. And so things like trying 3 first-line treatments before moving to adjunctive treatment is not, that's something that would be unique to the MCAG. That's what they recommend based off of their experience. But that's that would be an opinion of theirs. That's not in any clinical practice guideline. But the basis of it is all evidence-based. So you should always start with an SSRI or an SNRI, and those 4 specific treatments are the ones that have been studied the most and are relatively safer than the others. So hopefully that kind of answers your question. But this presentation, for example, is not meant to address something like the Durham will present when they're looking at antidepressants. That's kind of done in the MCAG meeting, and they are advisory to this committee, so we just wanted to present their work to you.
Well, with the Durham, we always get their evidence, and so we can assess the evidence. In this one, the preference for certain SSRIs goes against some of our evidence that says the SSRIs, at least for treatment of depression, are all equivalent, and there is no one that is better or worse. So I'm curious, is anxiety different?
There are nuances. I mean, there's some SSRIs are less tolerated, are harder to come off than others, like paroxetine, for example. And so they do add their, this is a guideline that they've developed that's based off the evidence. So they will call out specific agents that they feel have the most use and in practice and have shown to be well tolerated. So they do call those out because they are studied the most frequently and for GAD in the research, and then are commonly used in clinical practice. So PCPs, for example, are comfortable using these agents But that's not to say that anything else isn't effective. So if you go back to the algorithm, they don't specifically call out in the SSRI or SNRI, but they do have the dosing tables on the left there of specific agents that they feel are best to use in their opinion based off the evidence.
Okay, so
And
things.
Bill, I
have
just
been-
want to
Yeah, okay, go ahead, Roger.
I just wanted to do some level setting. So as Andrew mentioned, the Mental Health Clinical Advisory Group is advisory to the P&T Committee, but they're independently developing treatment algorithms for primary care physicians initially to be establishing therapy. And so you, the P&T Committee, are not being asked to approve this algorithm, to stamp it with approval or bless it. It's bringing it to your attention. This is independent. But some of the recommendations that are coming from the Mental Health Clinical Advisory Group may inform PDL placement in the future, as you said, is the purview of P&T. And in this case, as we get further into the review and what Sarah will be presenting, it's specifically around consideration of removal of PA criteria for pregabalin. That's the only thing we're really bringing to the committee for their consideration or recommendation to the OHA. So I just wanted to frame that so that this, as we continue to go down this path of this engagement between the Mental Health Clinical Advisory Group and their purview and their advisory nature to the P&T Committee, what you are being asked to approve, and it is not this algorithm. It is specifically going to be about a particular agent.
Okay, thank you. That helps.
Yeah, thank you, Roger. I guess I wasn't clear on that, and we didn't do that level setting earlier. So, Stacy?
Yeah, I don't have a question. I just have I want to give a on the record comment about how impressed I was with these algorithms. So I just finished updating our organization's benzodiazepine policy and am in the process of updating our collaborative practice agreements for anxiety disorder, which other clinicians use to kind of guide their treatment pathways as well. And these have been incredibly helpful. So whoever's in charge of this, I just wanted to publicly recognize the fact that these have been very helpful. So thank you for doing this and publishing them. It saved me a ton of work.
Thank you. I'll bring that back to them. I think they sometimes wonder how they're well used, and they're looking for ways to increase awareness of their publications so that more providers can use them. So I appreciate that. Thank you.
And Bill, to my comments that I was kind of setting the stage of how this engagement works, it's a two-way street. So, we present some of our materials and some of our PA criteria and our initiatives to the Mental Health Clinical Advisory Group for their input or questions, particularly because they have some child psychiatrists available. Similarly, as these algorithms come before you, if you have questions or concerns or, praise, like Stacey was just sharing, that's something that Andrew can take back to the committee. So it is a kind of a dynamic give and take, but that's just to help figure out this role and this collaboration.
Okay, I
I
think
have a
that's all I
question.
had.
I have a question. This is Erico. Is it so pregabalin needs PA for pain, radiculopathy, right? For which
We don't have a diagnosis available on the prescription, so it requires a PA for everything currently.
okay. So what
We
we're
don't know if it's for adjunctive treatment or if it's for pain or for fibromyalgia. We don't know when the prescription is billed by a pharmacy to us.
But the recommend so this recommendation is that remove OHP for pregabalin immediate release capsule product from the PA.
Correct. And so it could then be prescribed without prior authorization if that's your recommendation for pain or for fibromyalgia. That would be something that could result from that recommendation.
Oh, okay. And then how expensive is that compared to gabapentin?
And we'll get into that a little bit. We'll have
Okay.
Sarah's presentation.
Sorry.
No, I think it's a pertinent question. We really, but don't focus on that as much it's the safety, efficacy, and what we're looking for good treatment. But in general, I can say the cost has come down significantly for the immediate release pregabalin. It really isn't a very expensive medication.
Thank you.
Yeah, and so based on these recommendations from MCAG, we did want to take a look at our utilization. And so that's what I'm going to present next if there's no other specific questions on the algorithms. Okay, hearing none. So like we've been previously discussing, our current policy is PA required for all pregabalin, and the historical rationale for that has been to limit use to FDA approved and OHP funded indications. And in that PA criteria, we do require trial failure, contraindication, or intolerance to gabapentin. So they have to step through gabapentin before they can get to pregabalin. And so the questions that we were looking at specifically for this evaluation, we're looking at use with opioids or other sedating drugs, what medical diagnoses are present that might be potential indications for pregabalin therapy, who is prescribing pregabalin, and then if members were prescribed pregabalin, how many had a recent claim for an SSRI or SNRI, trying to get at that first line therapy for generalized anxiety disorder. So just a little bit of background. This will probably be old news for most of you, but it is approved for 4 pain-related conditions as well as epilepsy. But a lot of the literature references use for off-label indications that aren't supported by the evidence. Recent CDC guidelines for pain conditions suggested considering gabapentin or pregabalin for certain chronic pain conditions, including diabetic peripheral neuropathy, post-herpetic neuralgia, and fibromyalgia. Evidence shows that pregabalin does have a small to moderate improvement in pain, but it's not without adverse effects. So some of the common adverse effects include blurred vision, cognitive effects, sedation, weight gain, dizziness, and peripheral edema, and it does have that box warning for respiratory depression and overdose when used in combination with opioids. There are negative studies out there in the literature showing no benefit compared to placebo for a variety of chronic pain conditions, and the evidence comparing gabapentin and pregabalin is generally limited and of poor quality. So there's insufficient evidence to discern superiority as far as efficacy or safety when comparing those two products. So this was a 2-part evaluation. We used different methods to define each of these populations. We were looking over a year period from July 21 to June 22 for each of the populations. In this first population where we looked for indication, we wanted members to be eligible for 6 months before their first pregabalin claim within this evaluation window so that we could identify relevant diagnoses. We looked for both paid and denied claims, and this is a population that we also used to identify prescriber type and recent use for an SSRI or SNRI. When we were looking at combination sedating drugs, we used a shorter baseline period and had requirements for a 35-day follow-up period as well, because we wanted to try and identify that overlap with other sedating drugs. And then common exclusion criteria, just to make sure we have complete and comprehensive claims data. We excluded people with other primary insurance, Medicare or limited Medicaid drug coverage, and then people that didn't meet those eligibility periods for the baseline and follow-up. So a little bit of demographics for people that were prescribed pregabalin. About 65% of patients were female. The largest racial groups represented were white and Native Americans or American Indians or Alaskan Natives, which is pretty typical of our fee-for-service population. Only 15% of people in this study group had prior claims data for pregabalin, and part of that is how we identified claims. For this study, we were identifying people based on their first claim in the reporting period, and by doing that, it identifies more new starts, so people who don't have prior claims. And then the demographics for the two different populations did vary slightly, but this was generally consistent for both groups. So in looking at diagnoses that were present in medical claims in the 6 months before that first claim, paid or denied index event for pregabalin, less than half of members had an FDA-approved diagnosis that was present in their medical claims, about 48%. Another about 22% had an off-label diagnosis that was supported by compendia, so it might have had some evidence for use. And then about 31% didn't have an FDA-approved diagnosis or a diagnosis that was supported by compendia. So some of the most common diagnoses were diabetes or diabetic neuropathy, fibromyalgia, and other types of neuropathies. Some of the most common conditions without evidence for use were dorsalgia, chronic pain, and other anxiety disorders. And then looking at members with generalized anxiety disorders specifically, about 14% of members had that diagnosis in the 6 months before that first pregabalin claim. Comorbid diagnoses were common, so it's really difficult for us to determine why that pregabalin was being used. About 54% also had an FDA-approved diagnosis that would that might be the reason that the pregabalin was prescribed. And in patients who had that diagnosis of generalized anxiety disorder, less than half of members had a paid claim for an SSRI or SNRI within 35 days before that pregabalin claim. In general, our general practitioners are the primary people that are prescribing pregabalin, and that includes physicians, nurse practitioners, and PAs mostly. When we looked at overlapping use of pregabalin and other drugs that could be sedating, about 63% of members had at least one other sedating drug that overlapped by 5 days or more. However, opioids weren't very common with pregabalin, and that's the one that has the box warning for pregabalin. So that was present for only 7 patients.
Sarah?
Yeah.
I want to clarify that.
Mm-hmm.
There were 12% with overlapping, but it was on claims. So did you actually do either, like a sampling to make sure that they aren't actually getting opioids and just not, just paying out of pocket for these? Because that's probably the most common reason. If people are on chronic opioids, you don't get claims through the Medicaid program.
Yeah, that is one limitation of this analysis. This is looking at only claims paid by fee-for-service.
But you didn't go out and check, like say, do a random sampling of a certain percentage to see if they, because it would be on the PDMP.
No, we don't have access to the PDMP and fee-for-service to look up members. So yeah, we don't have any way to clarify for an individual patient if they got opioids or pregabalin at the same time.
So you really don't know.
Correct.
How many people are on opioids? Okay.
Is that broadly true that you don't have access to PDMP?
That's correct. Yeah. We need a data use agreement, to my knowledge, to get aggregate data for a population.
This is the state of Oregon's PDMP. It's just a highly restrictive. It's very unusual. All the state, it's behind so many of the states in terms of how other states use them. for public. They're emphasizing privacy over public health.
And unfortunately, Dee isn't here to speak to that, but yeah, the CCOs do have some access. Fee for service does not.
And so that,
Because I can tell you anecdotally, we see a lot of dual prescribing and a lot of complications, a lot of cognitive problems, motor vehicle accidents, emergency room visits, etc., with this kind of dual prescribing.
yeah, that's good information, definitely. And that does segue kind of nicely into my limitations slide, which is because it's a claims-based analysis, there is likely incomplete or inaccurate both claims and diagnostic data, and missing or incorrectly categorized data based on the definitions we used is possible. So we did only look for a short overlap period to define like that combination use and a short look back period to identify SSRI or SNRI use. So patients could be miscategorized there. We didn't do a comparison to gabapentin, which is available without PA. And so removal of the PA for pregabalin could lead to some increased use for combination prescribing, but it's unclear how much. And then we didn't analyze subsequent claims. So we were looking really at that first pregabalin claim and didn't analyze and what happened to those patients after that to quantify any delays in care or shifting of costs to members. Are they starting to pay cash, that type of thing. And so there's quite a few recommendations in front of the committee, so I'm going to break them up here and talk about the first couple. So our first recommendation is to make pregabalin IR capsules preferred based on the clinical evidence supporting use for generalized anxiety disorder. And then also to add generalized anxiety disorder to the PA criteria. And I'll stop there, and it looks like Bill has a question.
Yeah, so is this the place where I ask for the evidence? Because this is off-label use, so I think we have some obligation to review the evidence. And the efficacy of pregabalin for the approved indications is, I would say, modest at best. So I would like to know what the evidence says on this. Is it highly effective? Is it modestly effective? And based on what?
Good question. And I didn't get into it with this DUE. I don't know if Andrew can speak to that. I know generalized anxiety disorder is diagnosis that's compendia supported. And so with the regulations that we have in Medicaid, we're required to cover FDA approved or compendia supported diagnoses. And Andrew just put a link into the PA criteria or into the chat.
Well, I put the document, the MCAG document, on their treatment recommendations for generalized anxiety disorder that are publicly available. And so based off of the methods, pregabalin has high quality evidence for effect for treatment of GAD. It's recommended as a first-line adjunct with an SSRI or SNRI, but it also could be used as a primary treatment option for patients who cannot tolerate antidepressants. However, not everyone can tolerate pregabalin well. It is also a controlled substance with potential for abuse. And so that is their statement on pregabalin. There are several references listed there in the third page, I think. And so they're based off of the same methods that DERM uses, but they're not going to look like DERM documents because they're for providers. in busy practices, so they're very short and succinct. So there's a link there if there's any questions.
You know, that's not something I can review in 30 seconds while we're in the middle of a session. I would like to see a real evidence review on how effective this is. We do this for other things, including the things we have to cover. And if we're going to be using this as part of a PA that I have to bless, I would like to know what the evidence is. Otherwise, I'm really not comfortable making a decision.
That's helpful feedback. And so it sounds like your recommendation would be to table this until we can do an evidence review.
You know, that would be my preference, but I'm only one, so I don't get to decide unless everybody else agrees.
I agree.
I was gonna say, do you want to make a motion, Bill? I don't know if you want to make a motion and we can vote on it. Does everybody just want to maybe chime in?
I also like, I've heard about, well, like UK's been using pregabalin for a long time. I guess my also question is like, why now? Like, is it because of that there's so many requests for PA, so it's more administrative load reduction, or I am curious about why, and yeah.
Well,
From the mental health clinical advisory group, it was a barrier. Sorry, Andrew, go ahead.
The mental health clinical advisory group wanted to review anxiety because of the increased cases that they're seeing in clinical practice around the pandemic and everything. That seems they've just been seeing a lot of anxiety in primary care. They've also addressed that pregabalin PAs are a barrier to care for certain patients. And it's nice to capture those patients with treatment while they can without that additional barrier. So their recommendation is that there shouldn't be that barrier to pregabalin for treatment of GAD.
That's a separate issue from from how effective the drug is. And I honestly don't know how effective this is. That's not something that I have looked at recently. But I guess I will make a motion that we table this until we have an evidence review of the efficacy of pregabalin for generalized anxiety disorder.
Roger, is this something, or can I ask for a second, or is that making a motion?
Absolutely.
Okay, all right. So do we have a second for that?
Second.
Yes.
Okay. All those in favor?
Aye.
Aye.
Anyone opposed?
Aye.
Abstain? All right, thank you.
And just to clarify, for this evidence review, that's going to be strictly pregabalin for anxiety disorder rather than broader assessment of efficacy for other indications, because it does seem like the vast majority of our utilization isn't for anxiety when you infer from like concomitant SSRI use and such. So this is probably just a small piece of the bigger issue that we're biting into.
We have reviewed it for the other indications, but we haven't reviewed it for this indication. And I would like to know what it is and how it fits with the other standard treatments.
Kat?
Yeah, I agree with all that. I'm also seeing in the draft PA revisions in Appendix 2 that were going to be proposed. It seems like then it would kind of open it broadly to any indications. So it could be for anything as long as a person has had an SSRI, but they might have concomitant fibromyalgia or dorsalgia or some other non-FDA approved indication, and also happen to be on an SSRI for depression. And so I guess I'm just a little worried that even what was being proposed would automatically open it totally broadly. And I'd especially like to understand the negative studies that were mentioned.
Great point, Kat. I was going to bring that up, that the recommendation to remove the PA for the IR pregabalin wouldn't necessarily, to Pat's question, just be about adjunctive therapy. It would broadly be available then without restriction. So, Doug?
Yeah, I'm not as concerned. I'm actually in favor of its use in GAD. I think it's a lot more helpful and less of a problem than, say, benzodiazepines, which are down on the list. I'd rather have this used earlier. But I'm concerned about its broad use. I think that gabapentin and then now pregabalin, now that the price has dropped, is just being used for all kinds of musculoskeletal pain, and there's absolutely no evidence that it helps, but people are doing it because they feel that they don't have any other alternatives. And unfortunately, it's being added to some chronic opioids as well. And we've got a gabapentin pregabalin problem growing in this country.
I think that, I mean, at least my impression of that, though, is a lot of that came out of the most recent CDC guidance, because I mean, they're saying that we should be using a lot more of this before we use chronic opioids and things. So, I mean, yeah, I know that I think that certainly contributed to the increased use, is that, those CDC guidelines are promoting it. And I mean, and I also agree that there's a lot more anxiety out there that does not have a great solution. So I'm not opposed to this, but I also think that, again, having the evidence available certainly would be nice. So it sounds like our motion carried. And so I don't know, was there any other discussion or any other comments, or do we just want to wait and talk about this once it comes back?
Are we also going to get we're going to get the gabapentin also included in the evidence summary? Because isn't it gabapentin and pregabalin basically similar, right?
They are very similar, at least for treatment of pain. Pregabalin has more evidence for anxiety, but when we do a review, it sounds like it would be useful to evaluate all of the various indications, and some of those have been included in prior P&T reviews. So we might end up lifting some of that information and representing it.
Thank you. That'll be very helpful.
And so that'll more broadly include gabapentin, which is open right now. So defer the topic and bring back the evidence review for pregabalin and gabapentin.
Yes, that would be great.
Okay, moving on. Draw your attention to page 58 in the packet of materials, and we'll turn it over to Dave to talk about an update to the non-preferred drugs PA criteria.
Okay, thank you. So yeah, this is just a quick update regarding our PA criteria for non-preferred drugs and select PDL classes. We want to modify the criteria for non-preferred drugs in these classes to remove barriers for previously approved care, so we can provide a more efficient pathway for all these requests. So when OHP has already paid for a non-preferred agent and the prescriber wishes to continue, we thought it'd be prudent to allow a longer approval time to decrease those barriers to care, especially if the patient's already tried and failed other PDL choices. So if you look at the proposed changes, they're in red. In question number 2, we ask, is this a request for continuation of a drug and dose previously approved by the fee-for-service program? And then if it's yes, we advance the renewal criteria. We could look at that in just a few moments. Otherwise, we ask if it's for FDA approved indication. And then we ask, is the dosing consistent with FDA labeling? And so those were the added questions that we have in there. If we look at the renewal, we ask, has the patient failed to have benefit with or have contraindications or intolerance to at least 2 available preferred products? And if so, we've lengthened the approval, potential approval period to 12 months. And then if not, in question 2, we ask if the provider is willing to change to a preferred product. Otherwise, it's a shorter approval, at least until it's formally reviewed by the P&T committee, possibly 6 months or for the length of the prescription. So yeah, basically our recommendation is to update the non-preferred drugs prior authorization criteria to allow approval durations of up to 12 months for patients with a previously approved PA.
Thanks, Dave. Questions for Dave? Yeah, Eddie.
Yeah, I have a question. Just a little confused. Do you have an example, or what are the select PDL classes that we're talking about here?
Yeah, pretty much any agent that is not listed in one of our typical PDL classes kind of falls into this bucket. And so yeah, it would be kind of I don't want to say obscure agents, but agents that don't necessarily fit within a PDL class. But then yeah, Sarah, do you?
Gotcha. I think I understand.
Well, and it also applies to classes where we don't have clinical criteria. So where we just have preferred and non-preferred products. So like statins and beta blockers, we don't have clinical criteria for those classes, but we do have preferred and non-preferred products. So the non-preferred products would hit this PA.
Thanks. I think I understand now. I was just confused by the term select.
Good question. Thank you, Sarah.
Other questions for Dave? Thank you, Bill. We have a second?
Second.
Thanks,
All
Pat.
those in favor?
Aye.
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 Opposed? Abstain? Thank you.
All right. I'd mentioned at the top of introductions, we did have a resident joining us, Melissa Yokoyama. And draw your attention to page 61 if you're following along on the packet of materials posted to our website. But Melissa, you able to unmute your line?
Yes.
The floor is
All
yours
right,
for your policy eval.
Perfect. Thank you so much. So today we're going to be reviewing the glucagon-like peptide-1 receptor agonist policy evaluation. So just next slide. Going into some background about this drug use evaluation. So the purpose was to evaluate, to determine how the prior authorization revisions affected utilization of both metformin and the glucagon-like peptide-1 receptor agonist class among OHP fee-for-service members. And I'll be referring to the glucagon-like peptide-1 receptor agonist group by the GLP-1 RA, just to make it a little bit more seamless. And then the prior authorization requirements and medication status on the preferred drug list for medications to treat type 2 diabetes has changed over time. There have been many updates over the past years regarding current policies. So prior to 2019, all GLP-1 RAs were subject to clinical PAs or prior authorizations. And at that time, the only preferred was exenatide or under the brand name Byetta. And that was after two other medications, metformin and sulfonylurea for type 2 diabetes. And then for patients with OHP FSS, PA requirements changed in May 2019 to allow automatic approval for preferred GLP-1 RAs for patients that were currently on metformin. And so this auto PA eliminated the need to send manual PA requests for any of the preferred GLP-1 RAs at that time. And at this time of May 1st, 2019, exenatide and liraglutide were the preferred formulary options when the auto PA was initially implemented. And this was determined after evaluation of efficacy and cost. Next slide. So some of the key questions regarding the implementation of the auto PA for preferred GLP-1 RAs were, how has the prescribing patterns and utilization of GLP-1 RAs changed over time? What percentage of patients continue to adhere to metformin after initiation of a GLP-1 RA? And what are the common characteristics and comorbidities associated with those prescribed GLP-1 RAs? Next slide. And then going into our methods section. So this was a retrospective descriptive study, and descriptive statistics and percentages were used to evaluate changes between the cohorts, and patients were categorized by demographics and common comorbidities using ICD-10 codes. And then all paid FFS pharmacy claims for any GLP-1 RA from May 2017 to July 2022 were assessed and reported as per member per month to report utilization. And then in order to assess utilization of both metformin and GLP-1 RA and evaluate the implementation of the auto PA in May 2019, we made control and study groups of patients who were newly started on any GLP-1 RA. So patients with a new paid pharmacy claim for any GLP-1 RA from May 1st, 2018 through April 30th, 2019 was defined as the control group, and that was the pre-policy change. And patients with a new claim from May 1st, 2019 through April 30th, 2020 were defined as the study group, so post the PA criteria update. And then as for metformin coverage, the percentage of patients who continue to adhere to metformin after GLP-1 initiation was compared in the control groups and the study groups. And then metformin adherence was quantified by looking at actual daily coverage of the medication in the 3 months following the GLP-1 RA new start. And then for patients on metformin, the average percent daily coverage, or PDC, of metformin was described. Next slide. And then here we're looking at our inclusion and exclusion criteria. So we included all patients over the age of 18 that were enrolled in the FFS Oregon Medicaid, as well as patients who had the new pharmacy claim for any GLP-1 RA during the control and study periods. And then as far as the patients we excluded were if they had less than 6 months of continuous enrollment, or if they had any third-party insurance, and that was only for the metformin coverage analysis. Next slide. So this represents the utilization of GLP-1 RA use, and it's classified as per member per month from May 1st, 2017 through July 30th, 2022 for all of the OHP members. And GLP-1 RA utilization increased after the implementation of the auto PA in 2019, which is showcased by that orange line. So the orange line shows when that auto PA was implemented, and so we can see that upward trajectory of the use of this class of medication. And then just to put it out there, the green line does indicate when another medication was added to the preferred list. It wasn't part of our control or study group, but that was when dulaglutide was added as a preferred option, just to put into context as well for the graph. Next slide. And then going into the demographics that we collected, there were 85 new GLP-1 RA new starts in the control group, and then there were 129 in the study group. Baseline characteristics were pretty similar between the two groups. Most patients were between the ages of 35 and 64 years of age. Most were female, and most identified as white. There was also a slight increase in patients with a history of ASCVD in the group compared to the control, but there were also lower frequencies of hypertension and obesity between the two groups as well. Next slide. So this represents all of the types of medications in the GLP-1 RA class. So we'll look at that first or that second column in the table of the control group. So the number that is highlighted signifies what is the preferred medication in that timeline group. So in the control group, the only preferred option was exenatide, and then moving into the study group, we can see that there were two medications that were preferred. So that was exenatide, and then they added liraglutide as well too. So you can kind of see the differences between and how once the PA update was put in place and a new medication was added as a preferred, there were definitely seeing more liraglutide prescriptions in that study group when the auto PA was implemented, as well as when that was added as the formulary preferred option. Next slide. And then now we can look at metformin utilization between the two control groups. Again, we have to note that we did exclude patients with any third-party insurance to give us a more clearer picture of patients who were actually either on metformin or not on metformin. So in patients who had Medicaid as a primary payer, 67.9% in the control group versus 64.6% in the study group had claims for metformin in the 3 months before initiating a GLP-1 RA at baseline. And so this means that these patients were on metformin prior to starting a GLP-1 RA. And then of the patients who had metformin at baseline, most continued metformin after starting the GLP-1 RA. And we also looked at patients who actually started metformin after starting the GLP-1, and it was a pretty small number, but there were definitely more in the study group compared to the control group who started metformin after the GLP-1A. And then as far as the average percent daily coverage of metformin, it was pretty similar, 83.6% versus 85.8%. Next slide. And then this table represents the type of prior authorizations that were collected during the two study groups, but this also put back into perspective of the third-party insurance as well. So this describes the differences between the control and study groups among the types of PA that were requested for any GLP-1 RA. So in the year prior to implementation of the automatic PA, there were a total of 222 compared to 334. And then the proportion of fax and filling PAs decreased in the year after the change of the auto PA compared to the previous year, which could just be because more people were, or more providers were utilizing the auto PA because the patient that they were prescribing the GLP-1 already had metformin on board. Next slide. And then going into some limitations. So medication claims from pharmacies were used as a surrogate for metformin adherence. So when utilizing claims history data, the assumption is made that the medications of interest are being prescribed for the diagnosis of interest and not for any off-label use. And so delays in submission and processing of medical claims may result in incomplete information. And then we also analyze a lot of the comorbidities and baseline characteristics that relied on ICD-10 codes. So that also could be a limitation as well. And then patients with less than 6 months of continuous enrollment were excluded, which could lead to a lot of limitations in the study. But the OHP includes a significant proportion of patients who are only transiently enrolled in FFS. So often patients are quickly enrolled into a CCO upon eligibility and remain in fee-for-service for only a few months. And then as well as using a percent daily calculation to assess for medication adherence can also lead to some limitations since, using a PDC calculations may not showcase the patients who, are filling the medication but maybe not actively taking the drug. And then we also excluded patients with incomplete or atypical administrative claims data, which also limits the sample size and may not get a clear picture of the actual population that we looked at. Next slide. And then just some conclusion. So there was a consistent increase in utilization of GLP-1 RAs from 2017 to 2022, with a higher overall increase in claims after the auto PA implementation. So virtually most of the increased utilization occurred with liraglutide, which is consistent with the PA change when it was when it was made a preferred option with the auto PA update in May 2019. So GLP-1RA use among this patient population could have increased for several reasons, possibly for prescriber familiarity with this class of medications, expanded indications, or even recommendations by guidelines for their use. And then the changes in clinical PA criteria and increasing the number of preferred products from 1 agent to 3 over time may also have improved patient access by reducing barriers to prescribing. And then the change to the prioritization criteria to automatically approve preferred GLP-1RAs for patients may have improved access, like I said before, and then adherence to metformin was evaluated in this drug use evaluation because metformin continues to be recommended as a first-line agent for type 2 diabetes, and results regarding metformin use at baseline was lower than expected, given that it is a stepwise criteria to be required to do the automatic PA approval for the GLP-1RA. But we did see that most patients who continued metformin remained adherent in both groups with a percent daily coverage of over 80%. And then despite indications for use in cardiovascular disease and weight loss, there were relatively few patients with a diagnosis of ASCVD or obesity in medical claims, and no change in use in those with also diagnoses among control and study groups. Next slide. So after our drug use evaluation, our recommendations state that there should be no policy changes at this time.
Thank you. Very well done.
Agreed. Any questions?
I've got a question. Great job, Melissa. Does the auto PA require diagnosis of type 2 diabetes?
It
For
does
them
not.
to, was that Sarah?
Yeah, sorry for jumping in. I
Oh, no.
believe we're just looking for that metformin claim.
Okay.
We can't see diagnoses on the claim in the pharmacy system, and so we have to, we're not able to include that as part of the auto PA process.
Yeah, okay, that's what I thought. I just thought it was interesting. I think in your data, you were showing, it looked like the percent of patients with diabetes declined in the post implementation period. And I just wonder if that might be related to more utilization strictly for obesity in patients that don't technically have diabetes. Or if that's not even real at all.
Thank you, Edward. I think that is a new concern that I have based on this discussion. So we all know that the HERC specifically does not, well, let me not bring that, but the prioritized list specifically doesn't.
Actually, the fee-for-service or the whole Oregon Health Plan state plan with CMS
Yes.
does not cover obesity treatment.
Correct, but this would allow you to actually do it.
Yeah, not arguing that, just setting the stage as far as what the state is elected to cover obesity, which will be a topic that we'll review in the future.
Right.
Yeah, we don't call out that we intentionally wish to cover medications for the treatment of obesity. But that doesn't speak to whether or not we are doing that, unbeknownst to us.
Eddie, I think that's a great point. To that as well, though, if for the auto PA someone, if they did have obesity, they would also be getting metformin. So at the very minimum, they would have pre-diabetes. And then additionally, if they'd gone through the full PA process because they weren't on metformin, the diagnosis of diabetes would have to be included.
Right. I was just thinking about the folks that had pre-diabetes that were technically prescribed metformin. They could technically get prescribed liraglutide even if they didn't have diagnosed diabetes, full type 2 diabetes.
Correct. That's a great point.
If I could interrupt, sorry, this is Kathy Centena, but the criteria does ask if they have type 2 diabetes for the GLP-1s. So that might help clarify things just a little bit.
But
But I
Kathy,
think
if
they
it's a
only
pop-
you only encounter the criteria if you have to do a prior authorization. If it's auto
True.
adjudicating, then it wouldn't matter.
True, that's exactly right. That's exactly right. But if it is non-preferred, they do have to go through that step. So we could still be missing people. Yes, that's a great point.
Yeah, it would have been interesting to look at patients possibly just with prediabetes on their chart as well.
Good discussion. More questions? The recommendation is to maintain the current PA criteria. And so I guess we can entertain that first to see if there's a motion to approve.
So moved.
Second.
A second.
all those in favor?
Aye.
Right.
Opposed? Abstain? Thank you.
And then based upon some of the comments, is there some particular data like Dr. Carr that you were looking for us to go try to discern if possible?
Oh, you know, it's trying to close the barn door after. I mean, this
I
has been
hear
in
ya.
place. We're not going to undo it. But you know, this, you know, it'll probably be out on TikTok that all you need to do is get on metformin for a month, and then you can get on your obesity drugs.
Yep, I hear you. All right. Well,
It's
appreciate the
probably
discussion.
already on. It's probably already on
TikTok.
TikTok.
Oh, boy. All right, well, we'll continue on. Draw your attention to page 75 if you're following along the packet, and we'll turn it over to Kathy Centena. Kathy, are you able to unmute? You're still on mute.
Okay, sorry. Oh gosh, got all sorts of stuff going on here. There, can you hear me now, Roger? Sorry about that.
Yep, loud and clear. Thank you.
Okay, perfect. So yeah, the purpose of this new drug evaluation is to evaluate the safety and efficacy of a new diabetes drug called teplizumab or TZILD, and help to make policy decisions around that. Teplizumab was approved by the FDA in November of 2022, and it's indicated for use in adults and pediatric patients 8 years of age and older with stage 2 type 1 diabetes to help delay the onset of stage 3 type 1 diabetes. So we'll talk about these stages briefly in the next slide as well. Teplizumab is a CD3-directed antibody, which is currently the only approved therapy with this mechanism of action for this indication. So looking a little bit at the stages as a refresher, stage 1 type 2 diabetes is when there's autoimmunity, but normal glycemia and no symptoms in the patient. Teplizumab works in stage 2, in which there is autoimmunity characterized by islet cell autoantibodies. And patients at this time might have some dysglycemia, however, they're still pre-symptomatic at this stage. And then stage 3 is what we historically consider type 1 diabetes. And this is when they have autoimmunity as well as those overt hyperglycemic symptoms associated with type 1. Now, these autoantibodies are important because the individuals that have the persistent presence of 2 or more islet autoantibodies are almost 100% likely to develop type 1 diabetes. So determinants of progression to type 1 include the age of first detection of autoantibodies, number of autoantibodies, as well as their specificity and their titers. Another kind of risk factor for the development of type 1 diabetes, as you probably already know, is a family history as well. So kind of just to recap, teplizumab was approved to be used in people that have this confirmed, this actually next slide, please, this confirmed diagnosis of stage 2 type 1 diabetes. And this is determined by the documentation of at least 2 positive pancreatic islet cell autoantibodies, as well as this dysglycemia without overt hypoglycemia when taking an oral glucose tolerance test. Now, teplizumab is given IV daily over a 14-day time period, and they also recommend that you pre-medicate with an NSAID or acetaminophen, antiemetic, and antihistamine on days 1 through 5 at least of that time frame, as well as the patient should have some baseline labs done and age-appropriate vaccinations. So that's kind of a little bit of background on this drug, since it's a little bit different than what we normally see. But now let's go ahead and look at the mechanism of action. So teplizumab, it's a CD3-directed antibody, which binds to the CD3 surface antigens on T lymphocytes. It's a partial agonistic signaling and deactivation of the pancreatic beta cell autoreactive T lymphocytes. So basically what it's doing is it helps prevent the destruction of the beta cells. It also increases the proportion of regulatory T cells and the number of exhausted CD8 T cells in the blood, which basically this helps to moderate the immune response. We already talked about the FDA approved indications, so we'll bypass that. But let's go ahead and look at the 3 trials that were published on the efficacy of teplizumab. So the first one, the Harold et al. Trial, this phase 2 was actually used to support the FDA indication for teplizumab. And this was a double-blind, placebo-controlled, randomized controlled trial in patients median age of 13.5 years with a little bit of dysglycemia. Now, these patients were stage 2. They did not have a diabetes diagnosis, but they were at high risk for development of diabetes. So 100% had 2 autoantibodies, and 50% of patients had siblings with type 1 diabetes. There was also evidence of dysglycemia on their oral glucose tolerance tests. They received that one-time infusion over 14 days of teplizumab with a follow-up around 2 years. And the primary outcome was median time to progression to clinical type 1 diabetes based on the OGTT. And you can see there, number 1 is teplizumab. So that was 48.4 months before the development of type 1 diabetes versus placebo, which was 24.4 months. So teplizumab was found to delay the progression of the development of type 1 diabetes for about 2 years. So looking at the second trial, now this was also a phase 2 trial, but it was open label, and it looked at teplizumab over 14 days versus placebo in those patients that had already had a diagnosis of type 1 diabetes within the last 8 weeks of study enrollment. They also had the autoantibodies listed there. So they received actually 2 infusions, the first one at the time of diagnosis, and then the second one at 1 year. The primary outcome for this study was the C-peptide levels at year 2. And these are important because the C-peptide is an indication of an endogenous insulin production. And it was found that teplizumab did help preserve insulin production by a smaller decrease in levels, so minus 0.28 millimoles there versus placebo, which was minus 0.46 millimoles per liter, which was statistically significant. And then looking now at the last trial by Sherry et al., this was the only phase 3 trial which teplizumab was studied, and it was a double-blind, multi-center, randomized controlled trial in those 18 years of median age of 18 years. And this trial also looked at individuals that had recently been diagnosed with type 1 diabetes. And so this trial evaluated patients the trial follow-up was 2 years, but the primary endpoint was specified at 1 year. Now, this publication was an interim data publication. However, there was no follow-up. So that's why we went ahead and included this study. So what they found at that for the primary outcome at 1 year was that the composite of percentage of patients with insulin use of less than 0.5 units per kilogram per day and a hemoglobin A1C of less than 6.5% at 1 year was pretty similar between all the groups. Now, I should say numbers 1 through 3 are just different dosing regimens for the teplizumab, but none of them were found to be statistically different from placebo. And so therefore, there was really no demonstrated benefit of teplizumab related to glucose control in these individuals that had been recently diagnosed with type 1 diabetes. So some limitation to these trials, we only have the one small phase 2 trial really supporting evidence for the use of teplizumab in type 1 or for preventing type 1 diabetes. The study populations in these were predominantly white. However, there is a higher incidence of type 1 diabetes in that demographic. And they also, more than half of them did have siblings with type 1 diabetes as well. So it's pretty small inclusion criteria. The evidence also just pertains to a single course of treatment. And also there's pretty consistent evidence right now that we don't have high quality conclusive data to support the use of teplizumab in those already diagnosed with type 1 diabetes. So then looking at some of the safety concerns with this drug, the top 4 are lymphopenia, rash, leukopenia, and headache. The rash often spontaneously resolved and was not serious. But you can see the lymphopenia, there was a really high percent of that, usually with an nadir around 5 days, and then most patients did improve after that time period. Talking about a couple other safety concerns on the next slide. One is cytokine release syndrome. So this is an acute inflammatory syndrome characterized by fever and multiple organ dysfunction. And this did occur in 2% of patients treated with teplizumab versus 0% in the placebo group. There is also some concerns with liver enzyme elevations, and that's why those should be monitored at baseline, and then also throughout therapy, and teplizumab potentially discontinue in those that have significantly elevated LFTs. There's also been serious or chronic infections noted or seen with teplizumab, as well as lymphopenia, as just discussed, and potentially treatment should be discontinued if it is significant. And then, as I mentioned before, vaccinations should be provided to participants before they start this therapy. So the recommendations for PA criteria are the following, and we'll go ahead and just step through these individually since this is new criteria. Excuse me. Number 1 is that we ask that potential participants are of the appropriate FDA approved age. If yes, number 2, if the patient has previously been treated with teplizumab, because right now it's just approved for the one-time treatment. So if they haven't, go ahead to step to number 3, asking that this treatment's being prescribed in consultation with an endocrinologist. Number 4, just ensuring that they had those baseline liver function tests done, as well as a blood panel. Just again, consistent with labeling. Number 5, asking if the patients receive those age-appropriate vaccinations unless they have contraindications, and to have that documented. And then number 6, just ensuring that the person truly is at high risk of developing type 1 diabetes, or so that they are in stage 2 as indicated by the following. 1, the presence of 2 or more diabetes-related autoantibodies listed there. And they also have that abnormal glucose tolerance test within the last 2 months. And then if they meet all that criteria, then they would be approved for one 14-day course. So the recommendations are to include teplizumab with the miscellaneous anti-diabetic agents and designate it as a non-preferred product, and then implement the prior authorization criteria to limit the use to people with the stage 2 type 1 diabetes that are at high risk of developing that stage 3 type 1 diabetes.
One
job, Kathy.
question, I guess. Kathy, do you think that the sort of in PA line 6, the note about not approved for people with true type 1, will that be adequate to avert people from getting it as they did on the phase 3? Like kind of the horse out of the barn, you've already got diabetes, but we're going to give it anyways?
I think that's a great question. Thank you. I appreciate that. Number 6 was modeled after what was in the labeling, and I see your concern, and I'm not sure how to put additional restrictions in there to prevent it from being given if they truly do have type 1. We do know that those autoantibodies do disappear over time when you in true stage 3 type 1 diabetes. And so my thought process there is that they would not meet the presence of 2 or more related autoantibodies. Although if they truly were just diagnosed, they potentially could still have them. But other than that, I'm not certain. I definitely hear what you're saying. I'm just not certain how to put in any other restrictions.
Yeah, I don't know if other folks want to chime in, but would it be too blunt to just say like exclude individuals that have had like insulin prescribed? Or I see Bill and Eddie with their hands up, so I'll shut up.
Yeah, no, we could definitely, yeah, any insulin claims within the last 6 months or something. Sure.
Am I?
And we do have public comment, just to let you know. You can ask a few more questions to Kathy.
Am I correct in understanding that the evidence suggests this does not prevent progression to type 1, just delays?
You're correct. Yeah, that's a great point. And so in the trial data, and the full evidence tables are actually on page 181 through 84. I should have mentioned that. But so at 2 years, the teplizumab group, 43% of those patients had gone on to develop type 1 diabetes, where 72% in the placebo group had gone on to it. So yeah, it doesn't prevent it. It slows it, it delays it. The argument is that, and I think we don't have that data yet, but what does overall, I've heard, the earlier that individuals are diagnosed, the worse outcomes they have long-term and lifespan and things like that. But I don't think we have hard outcome data to demonstrate that. But that's the thought process. If we can slow that by 2 years, that hopefully then it would minimize those adverse outcomes down the road. That's a great question.
Bill?
This is a fascinating drug, but we're barely scratching the surface with this. It seems to have some effect on the autoantibodies, but when is the best time to use it? What is the dose? What is the regimen? And I don't know what delaying onset of diabetes from age 15 to age 17, what difference that will make when the patient is 20, 30, or 40. It's a good idea, but does that actually make any difference? We really have no idea. Plus, there's a really high rate of side effects on this. So I think a restrictive PA is necessary right now, and it'll be interesting to see what comes of this in the next couple of years, because this could prove to be wonderful, or it could fizzle and go away. But the results are mixed, and the benefit is uncertain. And I think the idea of eliminating people who are overtly diabetic, such as use of insulin, is a good idea.
So as I mentioned, we do have a representative from the manufacturer of this medication, Dr. Rushi Parikh. I don't know if I pronounced your name correctly. I've made you a co-host, so you should be able to unmute your line.
Yes, I can. Can you hear me?
Can hear you loud and clear. And so he is with the industry. They fill out a conflict of interest. That's generally sufficient for our committee to understand that you're here on behalf of Provention Bio. We provide up to 3 minutes for you to have public comment. I assume you have some prepared statements. After that, we'll allow the committee outside of your 3 minutes to ask you any follow-up questions if they have some. So with that, the floor is yours.
Understood. Good afternoon, everybody, and thanks for putting this together, Kathy. So it's a very nice, exhaustive look at both the history of the drug and the molecule itself, as well as some of the data that looks around it. So there's a few points that we had to bring up as a potential for amendment when looking at the DURM published data. One of which was on slide 41 and slide 42 that was presented just now. You can see in the diagnostic criteria for stage 2 disease, there's quite an exhaustive list of how to diagnose somebody as glycemic. I was wanting to make sure and ensure that that same diagnostic criteria or criterion, whichever is used by the physician, is applied in the in number 6, I believe, is where we then go back to saying only the OGTT was used. So I wanted to make sure that that was something that was discussed today. making sure we have access to diagnosing dysglycemia in any which way is already approved by the ADA criteria for diagnosis of dysglycemia. And then the second sub point under that same concept was the idea of obtaining an OGTT or a finding of dysglycemia within a 2-month span of time. And speaking to that 2-month criteria, it's really a question of where that 2-month number came from. And that's mainly a question of how it was obtained and how data was gathered in the TrialNet study TN10. So in the research world as compared to in the clinical outcomes world. So those were 2 small bullet points that we wanted to bring up when reviewing the literature that was presented today. In regards to the questions that were brought up, we can speak about them momentarily as well in regards to what is the worth and value of delay, as well as how do we diagnose somebody as truly a stage 2 patient, meaning they're dysglycemic and not an overt hyperglycemic patient in stage 3, which was a correct concern that was brought up just momentarily. So I will leave it at that and open it up to questions if anyone has any.
Great. Thank you, Dr. Parikh.
Yeah.
Questions?
Well,
Karen?
sorry, this is
Oh,
Kathy.
go ahead, Kathy.
Yeah, so I was just going to respond to number 6, the abnormal glucose tolerance and glucose tolerance test that came straight from the labeling. So that's where that came from. Certainly the committee is interested in adding different ways to define that. I'm open to that, but I just wanted to note that.
Yeah, no, I appreciate it.
Sorry, go ahead, Roger.
Karen, you had a question.
I had a question, but it was more for a reminder of how the billing of infusions work with regard to the pharmacy criteria versus medical billing. So how does, like, just kind of operationally, how does that work for a medication like this?
Yeah, I could probably take that question. It depends a little bit on the manufacturer and how they're marketing it. So they might be able to jump in here as well, but it can go through either route. So it can be billed as a physician administered drug, or it could go through specialty pharmacy and be billed as a pharmacy claim and shipped to the provider for administration. And what route it goes through kind of depends on how it's being marketed and managed. But we typically, unless there's good rationale for going one way or the other, we allow both. And so we can require a PA before administration for both of those. And that's where this criteria would come in. Hopefully that answers your question.
Yes, that was excellent. Thank you, Sarah. So the criteria is aligned regardless of if it's physician administered or if it comes through specialty pharmacy, the same criteria will be applied for use.
Correct.
Okay, excellent. Thank you.
Other questions? Either for the manufacturer or for Kathy? Okay.
If I
With
could,
that, the recommend.
apologies. I was going to say if
No.
I could been to take the 2 previous questions. One was just to confirm here on approval criterion number 6, and the OGTT shown in the PI or in the PA is completely appropriate, but we're just wondering, will that be expanded to include A1C both and fasting plasma glucose levels, and will the 2-month requirement be upheld or not? That was one question from my end. And then the second question that I remember hearing was, how do we essentially differentiate between stage 2 and 3? And that kind of goes into what is the worth and value of this. And so I agree, finding the patients who meet the criteria of truly a stage 2 patient is imperative for staying with label. With that said, we have to really understand how are patients being screened, if at all. And so obtaining autoantibody screening and then when patients are being followed up, when they are being tested with potential medications, like insulin exposure prior to translating into stage 3 disease is something we do see commonly. So I have seen patients who are stage 1 and stage 2 being placed empirically on medications, including insulin. But I think we should take a pause and look at a patient into 2 different ways in which to diagnose. One is the presence or absence of autoantibodies, which was previously mentioned can wax and wane with time, which is accurate. But along with the autoantibody findings, then the question of glycemic control for a patient. So is a patient normoglycemic, dysglycemic, or hyperglycemic, and with symptoms? And so if we can expand that sub point on bullet number 6, then we have a way to truly capture with some sense of accuracy, is a patient accurately dysglycemic and not frankly hyperglycemic. So that would be the way in which we would parse a patient, because the presence or absence of their glycemic control will then purport why and when patients should be rechecked for autoantibodies. So I don't know if that makes sense, but in real time, physicians have to find what to do when, based on, hey, I have a patient in front of me with 2 or more autoantibodies. Now, where do I categorize them? And then the opposite is also true. I have a patient here in front of me who's dysglycemic, coincidentally. Now, should I check autoantibodies? If there's only 1 positive, do I recheck? Do I not check? What do I do with that patient? So I think we have to look at it in a sequential process, if that makes sense.
Eddie, question?
Yeah, I appreciate that, those comments, because that addresses a question I had, which was whether patients in that stage 2 group could potentially be prescribed insulin. And so I was going to be wary of adding that language. But seeing as how under stage 3, it mentions diabetes by standard criteria, perhaps that could be used as a way to, do they meet diabetes by standard criteria? And if so, then this would not be approved as a way to distinguish between 2 and 3.
Yes, that makes sense.
So Pat, does that answer your question? And Eddie, are you proposing any changes to the criteria in front of you?
Yeah, I think that as long as there's a way to attempt to restrict maybe a little more formally from the stage 3 folk, I think that's fine.
And I would propose in criteria 6 to expand the criteria to align with the listed diagnostic criteria in the table. And then also to add a line, well, I don't know the best way to operationalize this, but essentially to add in a criteria that if they meet diabetes by standard criteria, then it would not be approved.
I see. Yeah, I see what you're saying. I think we could add that prior, maybe number 4 or something like that. And then, yeah. Or even number 6, and, we definitely put that in.
And then also to the question that was raised earlier, where did the 2-month time period come from?
I believe that came from the study, but I was just looking into that to verify it, and I haven't found it quite yet. But I would have to say that we did have this reviewed by an endocrinologist just to ensure the criteria was appropriate. And they did agree with what we were presenting here. So I think that, I can dig into that a little bit deeper if the committee's interested, but I just thought I'd add that little caveat as well.
If I may, the 2-month criterion, that is accurate. It comes from the TrialNet 10 documentation on how they created the actual study and the trial design. But if you look at the 4 other studies, A, this was not present, and B, the presence of 2 or more months in passing was really to confirm a patient to have accurate follow-up by TrialNet standards. So I agree that we need to have some sort of understanding of when a patient has definition of dysglycemia assigned to them. I mean, you can't say the patient was dysglycemic at the age of 6 and now at the age of 15, they now accurately remain that way. But the true understanding of the 2 months is more so a TrialNet design issue rather than a science-based one.
So I guess recognizing that we have to have some perhaps arbitrary timeline, 2 months feels reasonable. So I wouldn't think we need to change if, I don't know if other folks agree.
I agree with Pat. This is Karen.
Any other discussion? So again, the recommendation in front of the committee is to include the new agent with the miscellaneous anti-diabetic agents on the PDL and designated as non-preferred, and to implement the proposed PA criteria as amended to limit the use to people with stage 2 and high risk of progression to stage 3. We have a motion.
So moved.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
Great, thank you. Good discussion. Turn your attention to page 90. Again, if you're following along in the packet posted to our website, we have the growth hormone focused class update, and we'll turn it back over to Dave Ingen.
All right, thank you. We should be able to fly through this fairly quickly, but this is a targeted class review for growth hormone therapy in adults. And so today we'll examine comparative evidence for efficacy and safety of different growth hormone preps for adult growth hormone deficiency and other FDA-approved indications in adults. There's some specific FDA-approved uses for GH in adults. As mentioned, first and most commonly, it's used for GHD, growth hormone deficiency. This is due to impaired production of GH from congenital malformations and genetic defects, possibly acquired cases from trauma, infection, or malignancy. With GH, can also be used to increase lean body mass in HIV cachexia due to their altered metabolism and malabsorption from HIV infection. It's also approved for SBS, so short bowel syndrome, to help increase weight and nutrient absorption due to the reduced intestinal surface area or tissue damage associated with that disease. As far as systematic reviews, there's a Cochrane review that found a statistically significant benefit reported in patients with SBS who were also on parenteral nutrition. There's an increase of almost 2 kilograms of lean body mass compared to placebo. However, the evidence was low quality and the clinical significance of this finding is unknown. As for GHD patients, no high quality evidence was identified to support the clinical effectiveness of GH therapy on direct health impacts such as morbidity, mortality, symptom improvement, health related quality of life, and those types of things. For guidelines, NICE recommends that GH treatment in adults with GHD is appropriate when certain conditions are met. Of course, severe GHD, and if they have impaired quality of life, and when they're already receiving treatment for other pituitary hormone deficiencies. However, they also suggest the routine reassessment of ongoing benefit, and they recommend stopping therapy for GHD after peak bone mass has been achieved. Of course, therapy should be initiated by a specialist and continued in primary care with some type of shared care protocol. As far as safety, there are some safety precautions with GH therapy. Notably, it may be problematic in patients with diabetes, malignancy, as well as those with pituitary and thyroid dysfunction. Fluid retention is frequently observed with therapy. I've listed some contraindications here, but all the warnings, precautions, and complications with therapy are covered in greater detail in your packet. Before we get to the recommendations, there's some PA criteria updates that I'd like to go over. So if we could advance to the PA criteria, that'd be great. Yeah, so there's just some minor updates. We already went through the main changes at the December P&T, so those won't be highlighted here. But first, in question number 3, it's an EPSDT language update. And so you can see that. And then the next slide, number 5, it clarifies if it's an EPSDT request. And then number 11, we ask if preferred products have been used and can approve in those cases up to 12 months. And if you go to the next slide, you can see with the renewal criteria, this portion isn't really a new question. We just added some clarification regarding goals of therapy if the therapy is used for growth promotion in kids. So I've highlighted those changes. So I didn't know if there were any questions at this time. Happy to take those. And if there's no questions, in light of the current evidence, we'd recommend no changes in the PDL at this time. We'd also like to update the PA criteria as it's been presented and evaluate costs in executive session.
Kat, you have a question?
If you go back to that slide, it looked like NICE was recommending that adults discontinue once adult bone growth is achieved. And it seems like there's the only limit. Is that right? Where to go?
Yeah, it's.
Yeah. So that doesn't seem to be mirrored in these criteria.
We did at one point have that aspect in there. If I don't have the full criteria in the slides, but let's see, believe in the renewal criteria, it relates more to, growth hormone, if it's used for growth hormone deficiency in or for growth promotion in children. We have recommendation that it's discontinued if that growth velocity decreases. We have to less than 2 to 2.5 centimeters per year, and then should be reassessed in patients whose epiphyses are closed. So I don't know if that addresses the concerns, but mostly, that's geared toward, the younger crowd. But they did address it in the NICE guidelines. Not in great detail, but.
So does that mean for adults who only have growth hormone deficient, like not the HIV-associated cachexia or short bowel, but for only growth hormone deficiency, that it would just be continued indefinitely as long as there was a single quality of life improvement at one point in history?
Yeah, I think they're not specific in that, but they do ask that the patient be reviewed on a consistent basis. At least they have they initially said every 9 months, and then, you know, they don't necessarily say the exact, you know, time period to reassess, but I think what they're getting at is if there is a benefit in quality of life, and the patient is consistently receiving a benefit, then it's possible that it may be appropriate to continue that.
So to ask a question on top of that, Kat, are you recommending that in question number 5, we clarify that there should be recent documentation of improvement, like since it was last approved, or recent documentation of ongoing benefit?
I was mostly asking questions because I think that growth hormone deficiency alone in adults is newly covered, or recently newly covered. Is that correct?
Yeah, it's more of it's not as restrictive as it once was, but still it needs to be for, you know, an appropriate diagnosis, and we do have questions in our criteria that ask essentially what the goal of therapy is. So so that is, you know, consistently evaluated.
What do others think?
What are some of the, what would be like the appropriate quality of life metrics that would be documented to support ongoing therapy? Like, what are some examples?
Oh, bench pressing 150 pounds. You know, that's what is, I think Kat is talking about, right? The abuse that has occurred with growth hormone.
I'm worried about abuse and lack of comparative benefit for certain populations. Adult.
Exactly.
I agree. Did you mention that the NICE guideline actually had like a discontinuation strategy of like what is recommended for benefit? Like, is there an evidence-based guideline that we could use for supporting change to the criteria?
I mean, there are guidelines that address this, and in the packet, I've listed some of the more commonly used guidelines that address this, but like I said, they've been included for clinical context because of various issues with you know, the way that the evidence possibly had been gathered, or just not enough detail on how that evidence was gathered. But yeah, I mean, they're in our population, it's thankfully in the fee-for-service population, there's not a heavy use of that at this point, but you know, we try to keep on top of that, and we haven't seen inappropriate use, but you know, that doesn't mean that that's not a possibility in the future, but we've tried to ask the right questions to ensure that it is being used appropriately, and there's not barriers to care for people that have appropriate conditions that can be treated with growth hormone.
Other discussion or recommendation?
So Kat, how would we alter the criteria to at least to make sure that there is continued documentation of benefit with each renewal.
Yeah, that's why I was mostly asking questions rather than making
Yeah.
recommendations. That seems reasonable. I mean, I guess I'm a little disappointed that lean body mass was one of the outcomes rather than, I guess that was for the short bowel syndrome, but it would be really nice if there was meaningful clinically oriented outcomes that were continuously improved to stabilized over time that are more relevant to patients than lean body mass, for example.
Yeah.
Well, in the renewal criteria, it does ask about documentation of improvement. Do we feel like there needs to be more specific, like what that documentation needs to include or what it addresses? Because really, we wouldn't be talking about first-time therapy. We'd really only be talking about renewal criteria, correct?
Correct.
So I guess by having good, like, then maybe that makes the renewal a little bit less essential. For example, like growth hormone deficiency, maybe a lot of those people are like post neuro-onc tumor or cranial radiation, and you're not going to expect that your hormone is going to come back ever, which is probably part of the reason why it's going to be so hard to find a renewal clinical endpoint. Because like once you zap the pituitary, it's not coming back. And
Right.
so I would be inclined maybe to err towards not trying to hammer out some renewal criteria and assume that we're getting good initial approval for specifically for the growth hormone deficiency. Recognizing sure there is risk for abuse, but.
Right. How many claims do we actually have for this?
Yeah, not. As we'll see in executive session, there's not a lot of claims. So it's at this point, it's to my knowledge not an issue, but something to be aware of to make sure that it continues to not be an issue.
Right.
Yeah, unfortunately, the evidence doesn't speak to. There's definitely conflicting evidence as far as cardiovascular risk profile and bone structure and that type of thing. The studies are conflicting on that. So yeah, for other uses, there's not a lot of great data out there to support.
So what do we think about sticking with the criteria that are here? And if we see, if there are better studies or better data becomes available, we can amend, or if we notice that there is a concerning increase in prescribing patterns or something, we can always come back and revisit it.
That makes good sense. There is a change. Is it the next slide that we have the EPSDT? Were there any changes, Dave, to the criteria?
Oh, yeah. There were a few changes
right
for
there.
the EPSDT. Yeah. So.
So that's the recommend. I appreciate that, Stacy. So the recommendation then would be no PDL changes based on the review of the clinical evidence. Update the criteria as proposed, just presented there. And then we'll review an executive session, but we certainly can do a policy evaluation and look at our utilization, in the next 6 months. Is that sufficient? More discussion, or do we entertain a motion?
I make a motion to update the PA criteria as presented.
Second.
Great.
All those in favor?
Aye.
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 Opposed? Abstain? All right, thank you, everybody. Thanks, Roger, for, if we can take a look at that 6 months or whatever makes sense, that would be great.
Absolutely. We do have a 15-minute break slated. We're right on schedule, so let's take that break, and we'll see you after we have a short timeout. Thanks, everybody.
Okay, I'm gonna sign off.
And welcome back. Hope everybody had sufficient time to have a break. A couple more items to get to before we go into executive session. Looking at my screen just to make sure I see the members back. So if you're following along in the packet of materials, we're going to move on to the circadian rhythm sleep-wake disorders. And it's page 117 in the packet. And we're going to turn it back over to Sarah Servid.
Thank you. So I'm going to be presenting today evaluating medications that are used for circadian rhythm sleep disorders, and this includes both stimulants and sedating drugs. And circadian rhythm sleep-wake disorders as a class, there's several different types of them, are listed currently as unfunded on the prioritized list. And then to give you a little bit of background about our current management strategies in fee-for-service for our PA criteria, all drugs that are listed in the sedative class, so those are mostly ones with a diagnosis for treatment of insomnia, do require a PA with the exception of melatonin. Melatonin is available for members up to 18 years of age without a PA, and it's not covered for adults. Modafinil and armodafinil, which are stimulants, do require a PA for all use. Benzodiazepines, the ones that are carved out and have that mental health indication for treatment of anxiety, are generally available without PA for 30 days, and then any long-term use beyond 30 days does require prior authorization. And then as far as stimulants for ADHD, they have age and dose limits if they're preferred, and all of our non-preferred require PA. So that's a little bit of background, and just to go into some background for these conditions, circadian rhythm sleep disorders are caused when there's misalignment of a person's internal circadian rhythm and the external environment. And this manifests as both symptoms of insomnia when the person wants to sleep, and then excessive sleepiness when the person wants to be awake. So that misalignment with the external environment. Diagnostically, they can be categorized as intrinsic or extrinsic. Extrinsic are environmentally influenced, and intrinsic are more of that internal misalignment. So extrinsic can include jet lag and shift work disorder. Intrinsic can be classified as advanced sleep phase disorder, delayed sleep phase disorder, where that internal circadian rhythm is shifted either earlier in the day or later in the day compared to when the person normally sleeps. Irregular sleep-wake rhythm disorder, which is characterized by a variety of there's no one set sleep pattern for irregular sleep-wake disorder. You get a variety of insomnia symptoms and excessive sleepiness symptoms at various times throughout the day. And then non-24-hour sleep-wake disorder, which occurs most commonly in blind individuals, but can occur in sighted individuals where their circadian rhythm isn't 24 hours, consistent with our typical day. For most people, the normal light kind of entrains our internal circadian rhythm to match that 24-hour period, and people that are blind, they don't have that light input, and so that internal circadian rhythm gets misaligned with the external environment. As far as treatment options for circadian rhythm sleep disorders, guidelines recognize several different types of treatment options, of which medications is only one option. You can use prescribed timing of the sleep-wake schedule, so making sure you go to bed at a certain time, or timed physical activity or exercise to kind of stimulate and align that internal circadian rhythm with the time that you want to sleep. Either avoiding or exposing the member to light can also help kind of entrain that rhythm to the time and sleep pattern that they're interested in. You can also use somatic interventions to alter bodily functions and impact the sleep-wake behaviors. And then use of medications, which is going to be the real focus of this review that I'm presenting today, to shift that sleep-wake cycle and promote alertness when the member wants to be awake. So as far as drugs that are FDA approved for these conditions, there's 3 of them that have that FDA approval. Modafinil and armodafinil are approved for shift work disorder, and Tasmelteon is approved for non-24-hour sleep-wake disorder. And the outcomes that have been used to evaluate these drugs for circadian rhythm sleep disorders are some of the same outcomes that are used for treatment of insomnia. So there's really no minimum well-established standards in the literature for what is clinically important as far as improvement in insomnia symptoms or excessive sleepiness symptoms, but the American Academy of Sleep Medicine did propose some expert consensus minimum standards. And so they propose that a change in total sleep time of at least 30 minutes is probably clinically significant, and changes of more than 15 minutes in sleep onset, so the time it takes to fall asleep, sleep offset, and then sleep latency is probably clinically significant for patients. And so getting into the evidence, there were several systematic reviews that evaluated shift work disorder. And really, overall, there's insufficient evidence to compare any of these agents for shift work disorder. Modafinil and armodafinil compared to placebo seem to decrease sleepiness during the day by about 1 point on a sleepiness scale, on a 9-point sleepiness scale. Latency to persistent sleep was only improved by an average of 1 to 3 minutes in patients with shift work disorder with excessive sleepiness. And for most patients in these studies, excessive sleeping, or the latency to persistent sleep, so the time it took them to fall asleep, was still less than 6 minutes during a work shift, indicating that most of these patients, even when they were on modafinil, still had excessive sleepiness. So that doesn't necessarily meet those thresholds for a minimum clinically significant improvement. Serious adverse events were more common with both modafinil and armodafinil compared to placebo at 9.7% compared to 2.4% with placebo. There is some evidence that caffeine works similarly and reduces number of errors at work based on low quality evidence, but there's not enough evidence available from these studies to show that it prevents any injuries during the work shift. There is some evidence evaluating use of melatonin in shift work disorder with mixed results. Some studies show that it may help a little bit. Other studies have shown no difference from placebo. And there is low quality evidence of no difference in sleep latency. So the time it takes to fall asleep with melatonin compared to placebo. As far as other circadian rhythm disorders, 2 systematic reviews looked at melatonin in the use of non-24-hour sleep-wake disorder compared to placebo, and found insufficient evidence to support efficacy or safety for the use of melatonin. One systematic review also looked at a variety of pharmacological drugs for jet lag in athletes specifically, and found insufficient evidence for all pharmacological agents, including stimulants, sedative hypnotics, melatonin, and melatonin agonists. There is one guideline that was included in the review the American Academy of Sleep Medicine that was updated in 2015 recommended either melatonin or a melatonin agonist for some intrinsic circadian sleep-wake disorders, specifically for patients with delayed sleep-wake phase disorder based on low to moderate quality evidence, and for adults who are blind and have non-24-hour sleep-wake disorder based on low quality evidence. There is evidence to support use of melatonin or melatonin agonists in children and adolescents with neurologic disorders and that irregular sleep-wake rhythm disorder based on moderate quality evidence, and then insufficient evidence for most of the other treatments, including sedatives or stimulants, and other populations with intrinsic circadian rhythm sleep-wake disorders. And so circadian rhythm sleep-wake disorders are currently unfunded, and based on the lack of high quality data that melatonin or melatonin agonists, which have the most evidence, work well in these populations, the recommendation is to continue to limit use of sedatives and stimulant drugs to the FDA labeled and funded indications. If drug treatment is medically necessary for funded circadian rhythm sleep-wake disorders, or for patients who fall under EPSDT, we'd recommend coverage of a melatonin agonist or melatonin before they try other stimulants or sedating drugs, because melatonin seems to have been studied the most and may have some benefit for children, particularly in those with neurologic disorders. And then along with that recommendation to make at least one melatonin agonist preferred and evaluate costs in executive session. And so in order to support these recommendations, there are some changes to the PA criteria for both the sedatives and stimulant medications that have those FDA indications. This first change for the sedative criteria is mostly clerical and just kind of clarifying clarifying the duration of therapy for patients who request a sedative for palliative care reason. We got feedback from the call center that when we have a lifetime PA approval, they have to put in a specific duration of therapy, even if the intent is to approve it for lifetime. And so just modifying the criteria here so that it specifies a specific duration that would be expected to cover the rest of the patient's life, so that patients get similar criteria. So there's similar criteria for each patient. And then the subsequent changes kind of address the recommendations, the clinical recommendations for this class, providing a pathway to coverage for appropriate use in the EPSDT population for unfunded indications. So requiring documentation that the disease is of sufficient severity that it impacts the patient's health in question 14, and then asking whether the use is for a melatonin agonist for the circadian rhythm sleep-wake disorders, because those are the ones that have the most evidence of benefit for those conditions. And then the request, it would be approved for 30 days with subsequent approvals requiring documented treatment response. And then as far as the renewal criteria, after that 30 days, you go to renewal criteria, and in question 2, we'd ask if the request is for treatment of an unfunded indication, if the patient is still under 21 years of age and covered under EPSDT, have they had documented improvement of symptoms since the treatment was started? And if yes, then they could get approval for another 3 months. And so that outlines PA criteria changes for the sedative PA. And then for the sleep-wake medications that cover modafinil and armodafinil, those stimulants that are indicated for shift work disorder, these would be the proposed changes that we add to this criteria. So asking, providing a pathway under EPSDT for patients under 21 years of age, requiring documentation that the condition is of sufficient severity that it impacts their health despite lifestyle modifications. And then they could go through the criteria to get approval. So I think that's all I had. Any questions?
Good job, Sarah. There was no public comment, no one signed up. So the recommendations are in front of you. I guess I would amend the first one, continue to limit their FDA approved indications and update the criterion as proposed. And then if treatment's necessary, as it says there, consider coverage of a melatonin agonist or melatonin before a trial of the stimulants. We'll review an executive session, but make at least one melatonin agonist preferred. Do we have a motion?
So moved.
Second.
Doug. Thank you, Bill.
All in favor?
Aye.
Aye.
Opposed? And abstain? Great.
Thanks, Pat. You rocked it.
Woo.
All right, we're moving on. Final topic, page 147 if you're following along in the packet. And we have the ALS class update and new drug evaluation. And we'll turn it over to Sarah Fletcher.
Thanks, Roger. Yeah, the last class we're going to review today is amyotrophic lateral sclerosis. If you'll go to the next slide. This is going to be an ALS class update as well as a new drug evaluation on sodium phenylbutyrate taurursodiol. We're going to look at the efficacy and harms for the new product as well as evaluate the existing agents. And just as a background, riluzole was approved in 1995. It's the standard of care and does have some survival benefit of just a few months. And we conducted a new drug evaluation in July of 2018 when edaravone entered the market. Right now, neither of them have a PDL status, but edaravone does have a prior authorization attached to it. If you go to the next slide. There was one systematic review that I did include in this study. It was done by CADIT, and it's a summary of 4 of the phase 3 trials on edaravone. They had some differences in forced vital capacity for the baselines, and they were all fairly small. The primary endpoint, which I'll talk about a little bit more when we get to the new drug evaluation, but it was only significant for study 19. And study 19 is the one that was used for approval and was reviewed in detail here at PNT in July of 2018. They did not do a meta-analysis, but there are no significant differences for death and survival when looking just at the randomized control trials and not going on to open label survival or open label extension data. So if you go to the next slide, there were no high quality guidelines. There actually were no ALS guidelines that I did find in the when I did my review. And then next slide. There is one new formulation since the last time we reviewed this. Edaravone was only approved previously as an injectable, and now it has an oral suspension that was approved based off of pharmacokinetic comparison, and it's given either orally or via feeding tube. And this drug has a pretty unique schedule as far as administration, but the suspension does mirror that of the infusion, where they have 14 days on, 14 days off, and then for maintenance, 10 out of 14 days on and 14 days off. So you can switch from one to the other without a lot of confusion. Next slide. So for the new drug evaluation, this is on sodium phenylbutyrate and taurursodiol. The mechanism of action for ALS is unknown. The combination has been seen to reduce cell death in vitro. Both of these drugs are approved independently for other indications. Sodium phenylbutyrate is approved for urea cycle disorders, and so is its prodrug. And then taurursodiol is approved in other countries for bile acid production disorders, and its metabolite that you're probably familiar with, ursodiol, is approved here in the US for primary biliary cirrhosis. So the combination was approved to treat ALS in adults in September of 22. And if you go to the next slide, this approval was based off of a single phase 2 double-blind placebo-controlled study. It was sodium phenylbutyrate taurursodiol, which is a packet compared to placebo, and it's given orally or via feeding tube daily and then twice daily. There were 137 participants, and it was randomized 2 to 1. It was primarily male, white, and the average age was 57.5 years. This disease does affect men about 2 to 1 compared to women, but it's not primarily, or it's not only a disease of people who are white or Caucasian. So that's not necessarily reflective of all patients with ALS, but the age is appropriate. The major inclusion criteria were those with definite ALS by the L-Escorial criteria. There's some other like probable, lab supported probable, other ways to define this disease. And often people who initially present as probable will move to definite once they've progressed further. It had a slow vital capacity, which is similar to FVC, but it doesn't have the 1 second time that exceeded 60% for age, sex, and height, and patients did not have tracheostomy when they were admitted to the study. The duration was 24 months, and the primary outcome was the rate or slope of decline of the ALS functional rating scale, which was the revised version from baseline to week 24. So the MCID for this, or the minimum clinically important difference, is not known. Cadith said that a difference of 2 points over 6 months might be clinically significant if replicated in multiple studies. Surveys of other clinicians have said that a difference in slope of about 20 to 25% from the treatment might be clinically significant. And patients generally are thought to decline by about 0.92 points per month, and it's not known if that decline is linear over the course of disease. So for the primary endpoint here, you can see patients declined on this 0 to 48 point scale by 1.24 points per month with the sodium phenylbutyrate taurursodiol and 1.66 points per month with placebo. And that was a difference of 0.42, which was statistically significant. If you go to the next slide, the FDA review of this had a number of concerns with the statistical analysis. They did assume linearity with the ALS-FRS change over time. And when a different model that did not assume linearity was included, it was not statistically significant. There was also more attrition in the active drug group compared to the placebo group. And there was an MITT population that was used that excluded 2 patients that died in the active drug group who didn't have a follow-up assessment but did receive active drug. And then there were some other unverifiable missing data assumptions that the FDA noted. So when they did the analysis, the FDA basically recommended that it should not have been functional status alone. There should have been some assessment for what happens if a patient died. And so a post hoc joint rank assessment was done where patients were ranked first by time of death and then by decline in functional status. And when the investigators did that, they again said that it was statistically significant or found a statistically significant result, but lab observation carried forward was used for this missing data, which in a chronic debilitating disease is usually not considered appropriate. So when the FDA redid a joint rank assessment, they did not find statistical significance in either the MITT or the ITT population when they used a multiple imputation-based model. So I think that I just wanted to point out those limitations. If you go to the next slide, there were 12% of patients had serious adverse events with the active drug and 19% versus placebo. The discontinuations due to severe adverse events were none of the 1% or 6% were thought to be actually due to the drug itself. For discontinuations due to any adverse event, there's 19% for the active drug, 8% were thought to be due to the drug itself, and for placebo, 2% out of the total 8%, or 2% total were thought to be due to drug. There were 5 deaths in the active group and 2 in placebo, and again, it was a 2-to-1 randomization, so the groups were not equal. And the primary or the most common adverse events were gastrointestinal disorders, and those were basically the top 3: nausea, vomiting, that type of thing. There are no contraindications for this medication, but patients with intrahepatic circulation disorders, pancreatic disorders, and intestinal disorders were excluded and should be used with caution because taurursodiol is a bile acid, and it's thought that they would have increased diarrhea and altered pharmacokinetics. Those patients and those with cholecystectomies were excluded from the trials. And then also this drug product provides almost a gram of sodium a day. And so patients who are sensitive to that, that should be something to monitor for. Patients with uncontrolled hypertension were excluded. And especially with the gastrointestinal disorders and that sodium sensitive disorders, I wanted to note that because the placebo was a packet that's dissolved and ingested, it had to match taste, bitterness, all of that. And so it had a lot of excipients, including sorbitol and sodium phosphate. So when analyzing the some of the adverse events, that's important to take into account. We go to the next slide. I'm recommending a new PA for this new drug, and it's pretty streamlined. It's restricted to just the FDA indication. Because riluzole is the standard of care, patients to take concomitant riluzole, which was allowed during the study itself. And this is done under the consultation of neurologists, as well as restricting to those with the low vital capacity of greater than or equal to 60%. And if you go to the next slide, the last question is for a baseline functional status rating and then renewal criteria, because it's not a fully black and white what clinical efficacy would be as far as a minimally clinically important difference. We're just asking for the prescriber to attest that they think that it's affecting the slow in a meaningful way. And then if patients have progressed to tracheostomy, we recommend that they not continue this. If you go to the next slide, edaravone has a separate PA, and I've listed that on page 165. It's quite similar to this, though some of the baseline characteristics were slightly different based off of their trials, but my changes that are recommended are clerical. So I've updated the dosing table to include this new suspension. I've simplified the renewal criteria. It requested a neurologist, which was already an initial criteria, and then I've removed funding questions because this indication is funded. And so to avoid having to change the PA for EPSDT, I just removed the questions. So if you go to the next slide, my recommendations, currently none of the drugs in this class have a PDL status. So I'm recommending that we make riluzole preferred, to designate edaravone and sodium phenylbutyrate taurursodiol as non-preferred, and to implement a PA on the new medication, as well as update the edaravone PA as proposed. And then finally, to review costs in executive session. So I'm happy to take any questions.
Good job, Kathy. And there's no public comment that I was made aware of. Questions for Kat or for Sarah? Not seeing any questions. So we would entertain a motion to add these drugs to the PDL and make the recommendations. Thank you.
Second.
All in favor?
Aye.
Aye.
Opposed
Aye.
and abstain?
And Dr. Onishi, I think you got in right before he switched, or right after he switched over, but that was the approval. Was that correct?
Yes, sorry.
Okay, gotcha.
Sorry about that.
No, I appreciate it. You stepping in. So awesome. Well, that concludes the business we want to attain in the open session. We need to adjourn to executive session. Sarah is setting up a breakout room for us. I need to read announcement, and just for the audience's awareness, we will not conduct any business in executive session. We will return back to open session and take final recommendations before we finish for the day. So with that, the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. The executive session is held pursuant to RS 1926602F and ORS 4143561 and 2, which allows the P&T committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that is necessary for the committee to make final recommendations or to comply with the requirements of ORS 4143553. Representatives of news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representatives of news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. Thank you. All right, we've concluded our business in executive. This is reviewing the confidential pricing. We're just going to do a head count and make sure that we have. I'm working with screens that are fighting me a little bit. And if the committee members can unmute, Bill, I see you've unmuted yours, but for the rest, it'll let me do a head count. 3, 4. Eddie, are you able to unmute? All right. So I'm going to lump the recommendations together. So after review of confidential pricing and executive session, the recommendation for the glaucoma drugs is to make bromonidine tartrate 0.1%, which is generic alpha-GAN-P ophthalmic drugs preferred. For the growth hormone for adults, there's recommendation to make no changes to the PDL. For the circadian rhythm sleep disorder class review, after executive session, the recommendation is to make Remeltion tablets preferred, but those will still require prior authorization. And for the ALS class update, after executive session, the recommendation is to make Riluzole tablets preferred and the Riluzole film and suspension non-preferred on the preferred drug list. So with that, we need a motion to approve those recommendations.
Move to approve?
Second.
All those in favor?
Aye.
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 Opposed? And abstain.
Great. Thank you very much. And again, Pat, thanks for stepping in for Stacy while she's doing the downward dog. And the next meeting of the P&T committee is scheduled for June 1st. So we'll send out materials as we get closer to that date, but appreciate all of your attention and good questions. And we've got some takeaways to bring back information. So thank you all. And we've given you back about 48 minutes this time. So thank you very much, everybody. Take good care.
Have a great evening.
Thanks.
Thank you.
you.
Thank you.
Bye.